HBV virus infection is a major health problem, and we consider that 400 million people are affected with this infection all over the world, especially in eastern countries, and about 500,000 people die with this, the complication of this disease all over the world in each year. So, in the late 80s, many liver transplantation centers doesn't consider HBV infection to be a good indication for liver transplantation, because the very poor survival rate, inferior to 50%. But after coming of immunoglobulin and lamivudine, these two drugs had changed this scenario. In fact, now in the late 90s, we see that HBV infection is one of the best indications for liver transplantation. But we consider a great risk of recurrence. In fact, this risk is very high in E-positive patients and in patients with high pre-transplant serum HBV DNA titers. This risk is very low if we consider E-negative patients, patients with fulminant HBV infection, patients with delta co-infection, and patients with low pre-transplant serum HBV DNA titers, and also with patients who consider a long-term immunoprophylaxis. And this is the first group where demonstrated this one is still 1993, the group of Didier Samuel, Paul Bruce and Perez. In fact, this scenario has changed with this coming of these drugs. Immunoglobulins was first introduced in the early 1990s, first group of Hanover, but also it consolidated by the group of Paul Bruce. The mechanism of these drugs is not well established. There is maybe a block of a putative HBV receptor binding to a neutralizing circulating virus expressing surface antigen, inciting lysis of infected cells. But this is its response is dose dependent. In the last year, we have seen many schedule of treatment, but in the 2006, again the group of Paul Bruce, Roche, and Didier Samuel had approved this schedule, which consider the status of the patients before transplantation. In fact, as we see, patients with HBV DNA PCR negative patients doesn't need a preoperative antiviral therapy before transplantation. Instead, the patient with PCR positive needs a short course, more than 4 weeks, in lamivudine therapy, 100 milligrams. So, in the anapatic phase, the patient received 10,000 units in intravenous immunoglobulin, followed by a first operative week, 10,000 units per day of immunoglobulin, intravenous immunoglobulin. So, in the post-liver transplantation phase, we see that the patient received 10,000 units in intravenous immunoglobulins to maintain anti-S titer, more than 500 units in patients who were PCR positive before transplantation, and it's sufficient to maintain a titer of more than 100-150 units if the patient was PCR negative. But the monotherapy is not so promising, and the problem is the high cost, especially in the developing countries. The other problem is the recurrence. especially during the first 2 years post-transplant, maybe due to escape mutation and determinant of the surface antigen. And we have to consider the adverse effect, hypersensitivity reaction, and the immunocomplex disease. So, in the last year, we have used the intramuscular immunoglobulin on a fixed weekly to monthly schedule or given on demand. There are many papers who demonstrated this one. In this paper made by MAMS in 2008, we see that intramuscular immunoglobulin are better than intravenous administration. And in this paper, it is a head-to-head study who demonstrated that the titers in NTS is the same in the two groups. This is other paper made by Patrizia Burra in Padua who demonstrated also the same. Low intramuscular immunoglobulin has the same titer in intravenous compared to intramuscular. And so this is another example in which intramuscular immunoglobulin provides a safe and effective prophylaxis less than 10% the cost of the high-dose regimen. The regimen, the immunoglobulin given on demand is more cost-effective because it needs a more intensive monitoring of NTS titers. And this is another example that intramuscular immunoglobulin are really cost-effective. In fact, the cost of intramuscular immunoglobulin is about $750 compared with $100,000 in intravenous immunoglobulin, and this high cost includes nursing time, pharmacy preparation, solumedrol infusion before injection, and the recovery time. Now we consider the discontinuation of immunoglobulin. This is a paper in which, made by Wong, in which a series of 21 patients had withdrawn the immunoglobulin prophylaxis followed by a maintenance in nucleoside analog therapy. In this series, we the others saw only a transient surface antigen and HBV DNA. This is another example made by the group of Angelico in Rome, more recent, 2012, 11, in which the patient had withdrawn the immunoglobulin, followed by the short course of NUCs, followed by a withdrawal also of the NUCs. In this patient, the rate of recurrence is very, very low. But this group had undetectable HBV DNA before liver transplantation. The vaccination is truly ineffective. In fact, the success rate is up only 80%. Now, the nucleoside or nucleotide analogs show a really good, convincing tool in this patient. In fact, lamivudine is able to inhibit the HBV replication. It has an excellent short-term result in monotherapy. It's more economical and convenient compared to immunoglobulin, but it had any problems. Its rate of recurrence at 1 year is more than 10%. We increased to 40% at 3 years. Due to emergence of resistant mutants can result in a rapidly progressive liver disease, and so this monotherapy is very insufficient. In fact, also in this meta-analysis, we can see that the rate of recurrence is about 40–60%. And the problem of the resistance to lamivudine is due to mutation, to YMDD, and so we need a combination therapy. In fact, in this paper made by Marzano, he had used a combination prophylaxis using immunoglobulin plus lamivudine, and he had demonstrated that the rate of recurrence is less than 5% compared to the control group who had used only immunoglobulin, in which the rate of recurrence is more than 50%. He had demonstrated also that the rate of recurrence is lower if the patient had a pre-transplant titer of HBV DNA more than 100,000 copies per ml. Now, have NUCs the potential to overcome the immunoglobulin needs? First of all, we have to consider which is the endpoints in the cure of HBV infection. We had two surrogate marker, which is HBV DNA, And the solid endpoints, we are the surface loss, surface antigen loss, the seroconversion to NTS, and the cccDNA elimination. But what are the facts? The facts are that only interferon, but in a rate about 20–30%, had reached this result. But the more potent drug like entecavir and tenofovir does not. And they have a drawbacks, which are the high cost, the resistance, the compliance, and the impairment of renal function. But more recently, in the years held in Barcelona in 2012, I will to show to you two abstracts. One of these is made by the group of Rio, in which 65 patients undergoing to liver transplantation for HBV and received entecavir 1 mg plus immunoglobulin, and the efficacy was evaluated at 72 weeks. And we see that at 72 weeks, the surface antigen loss, the rate of this loss is more than 90%. Its seroconversion to NTS is more than 80%, and the surface antigen recurrence is more than 3%. This combination is very safe. In fact, no one patient had discontinued the therapy due to adverse effects. Also, the using of tenofovir and emtricitabine plus immunoglobulin after liver transplantation had a good results in these patients. But we have to remember that the loss of liver HBV DNA does not equal viral replication, because the cccDNA and so the acute HBV after liver transplantation need a lifelong prophylaxis. So in conclusion, the immunoglobulin monoprophylaxis is actually the gold standard in non-replicator CD4 liver transplantation patients. The monoprophylaxis with lamivudine without immunoglobulin or after the withdrawal is less effective in replicators and lung-resistant variants. The vaccination is also controversial now, and the low dose of intramuscular immunoglobulin and NUCs is effective, well tolerated, and less expensive. This is a personal series made with the group of Luciano Tarantino, and we observed 27 patients, 22 with only HBV infection, 3 with infection with Delta association infection, and 1 with triple infection with HCV. Our protocol of therapy is this 26 patients had combination therapy, 23 with lamivudine, 1 with lamivudine plus tenofovir, and 2 with entecavir. Only 1 patient received only immunoglobulin. The mean timing of injection is 30–45 days, and the NTS level is about 500 units. We follow the patient with HBV DNA titer every 6 months. We don't see any adverse effects. In conclusion, the combination of long-term lamivudine and low-dose immunoglobulin on demand or fixed intervals can prevent HBV recurrence rates in more than 90% of patients. HBV prophylaxis should be individualized, so it's very important the pre-transplant HBV DNA levels, the presence of drug-resistant variants, co-infection with Delta or HIV, and the risk of HCC recurrence. The discontinuation of immunoglobulin with continued long-term nucleoside or nucleotide analogs treatment is another strategy, but it's important only in patients with low HBV DNA levels pre-transplantation. Also, immunoglobulin-free prophylaxis is best suited for this patient, but they must have a low baseline risk for HBV recurrence, as a low titer of HBV DNA before transplantation, and also a low titer of HBS titer. Effective antivirus therapies exist to rescue patients who fail initial prophylaxis, and we have to remember that HBV persists in the liver, in exhepatic sites, and it serves as a source of reactivation of the infection. And so this is a problem, and it needs an indefinite prophylactic therapy in most patients. Thank you for your attention.
Any question? A simple question from me. If
It's a question from
question, excuse.
the microphone. Yes,
she has taken domino liver transplantation. HB immunoglobulin too expensive, so I use HBV vaccination monthly, continue 2 years. Now he had HBV disappeared, and she has only lamivudine. I have one case. Vaccination, please try.
In your patient, you don't need the immunoglobulin. You have only vaccination plus lamivudine.
Monthly. Monthly.
Monthly vaccination. Excuse me, I not understood.
In the first 1 year, I use immunoglobulin. However, another 9 years, she didn't need
Eight cards.
Oh, yes.
Okay.
Is this just a favorable cases and other cases you didn't get the same result, or is it the only case you treat in this way?
Yes. I have only 5 liver transplantation patients, so I can another case, but she is very well, she is very good.
May I ask, but you treat together with the immunoglobulin or without? Just vaccination?
Yeah.
And how could you decide?
I see the usual S antibody. After 2 year monthly vaccination, her
Okay, thank you.
Beppe, if intramuscular therapy is so efficacious than intravenous, why there are few patients that practice this modality of immunosuppression?
In our land, in our setting of patients, we use only a few intramuscular, but the problem is that the patient fall in love with the intravenous administration. And our problem is to convince patients, especially those one who had made the transplant many years ago, and they are not convincing to change to intramuscular. So this is our work. I think that we have to work for convincing them.
Okay, then thank you for your nice presentation, for the interesting discussion. I want to introduce Dr.